there's hospitals and then there's primary care, and perhaps part of the challenge here is not seeing them as so separate. And rather than seeing primary care as supporting hospitals, primary care is an enabler. And our next speaker is Professor Claire Jackson. And Claire is going to talk to us about this very point. Claire has some incredibly long titles and connections. I'll let you use the app to see those rather than taking up time now. I think it's more important that we hear from Claire.
Thank you very much. Thank you very much, Ursula. Thank you very much, all of you, for a most fascinating couple of days. And thank you, Catherine, for setting up the presentation so nicely. Healthcare integration. Why is it so hard to deliver and sustain? Well, our gentleman on the left has occasional episodic healthcare and is very happy with the healthcare system. But the young woman on the right needs an incredibly skilled, diverse team across settings, across social and health sector to give her the best health outcomes possible. And I think the best summary I could find around where we stand now is this one, which comes from our Australian health policy literature. Changes in the community's health needs and in healthcare practice demand corresponding changes to the structure and incentives for Australia's healthcare system. An increased prevalence of chronic health conditions, expanded use of non-inpatient and ambulatory care in numerous service areas challenge the historical separation of hospital and community care, and pressures for improved productivity and efficiency in the delivery of healthcare are profound. So these are the following features of a well-integrated health system: incentives for best practice care and for productivity and efficiency, scope for substitutability and flexibility, service models which encourage continuity of care, devolution of administration and service delivery, and clear roles, responsibilities and accountability between levels of government. Now, I saw you all out on the dance floor last night, so I'm going to wake you up with a multiple choice test. So who in the audience thinks that comes from our recent health policy work around the last 3 to 5 years? Put your hand up high. Okay, who thinks it might have come from the document Catherine discussed, the National Health and Hospital Reform Commission Blueprint for Australia 2020? Hands up. And who thinks that that came from a communique right here in Brisbane from the Special Premiers Conference? And sadly, you would be right, because that description 30 years ago would match exactly what Catherine has been speaking about this morning. And when I haven't taken my Prozac for a few days and reflect on where health system integration has been going over my professional lifetime, I wonder whether it's going to be a pursuit as old as Methuselah and I'll be in residential aged care and people still be worrying about how I'm going to be looked after. We've had tomes of policy reports, announcements and commitments internationally, but there is so little evidence of improved patient-level service continuity of care at scale. So why is it so hard? And what can we do to progress it using today's levers? And I'd like to approach this from two themes. First of all, Einstein's wonderful statement that you can't solve problems by using the same kind of thinking we use to create them. And the catch cry from Greenpeace that has been so successful: think global, but act local. And we're all trying to do the same things internationally to respond to international healthcare needs and change. We're trying to increase the relevance, funding, capacity, and accountability of the primary care sector to do a lot more heavy lifting into the future. And we're trying to integrate that sector much more strongly with acute, private sector and social care. We're trying to focus on whole of system planning, funding and service delivery, delivering advanced care within the community where people work and live, linking incentives with the desired structure and function that are evolving, being much more innovative around using and digital health, and focusing and meeting and measuring what the US have described as quadruple aim. Much better quality outcomes at patient and community levels, much more efficient delivery of care, and much happier receivers of care and deliverers of care. And as the old Irish joke says, as the tourists ask the Irishman the way to Dublin, if I were you, I wouldn't start here. We all have different health systems that are our traditional starting point. They have enormous strengths, but they all have specific frailties. And so internationally, we're all having a different go at trying to move our health systems forward. The USA has moved from a very strong focus on fee-for-service to blended funding models, and they've invested in accountable care organisations, which is an approach to vertically integrate the care that's delivered in the hospital, community, aged care and social sectors. And they've really revolutionised their delivery of primary care to a patient-centred medical home model. The UK in 2014 announced their 5-year forward view of their healthcare system with an alphabet soup of different acronyms, which I haven't time to go into today, but they all focus on a common theme: better vertical linkage between acute care delivered in the hospital and community service provision. And the Kiwis have moved to a blended funding model in general practice, a fee-for-service system now complemented by a capitation service, but they've also worked very hard on their regional service delivery integration. They now, with alliance contracting, require all primary health organisations and district hospital boards to be working together with their service deliverers in the community to pool funds and to really look at the wicked problems in service delivery and better healthcare and to work on them collectively. And they are now expanding their healthcare home model broadly across New Zealand. And in Australia, we've commenced our own healthcare home pilots. Wentwest and Western Sydney are most definitely the most advanced, but they are running through Commonwealth trials and initiatives and pilots that are occurring in most primary health networks across Australia. Importantly, our Council of Australian Governments have also committed to joint Commonwealth state commissioning and funds pooling. So at a macro level, thinking globally, we're starting to see quite significant shift in the policy environment. But what we're missing is the opportunity to act locally. And 10 years ago, which was roughly 10 years after our unit started working at local, state, and national level in a myriad of fabulous service integration initiatives, we looked around after 10 years and most of them were gone. They'd had fantastic, passionate clinicians, great health executives, hospital support, funding, but after 3 to 5 years, they were no longer there. And so we searched the literature and we did quite a lot of qualitative work to work out what it was we need in sustainable service integration. And we created the SIF, or the Service Integration Framework. And it had 5 key tenets. The boundary, the ground level building block for good, sustainable service integration was change management. A common vision, bringing all the folk that are going to be delivering the new service model together to brainstorm the enablers, the barriers, the opportunities, the drawbacks, and to come together with a single approach to what they were going to do. And then, obviously, you need an integrated clinical model of care across the continuum, across settings and disciplines. You needed to train your health professionals and others in those teams to work in a different way. You needed to have savvy communication, information technology, but also a way for the people delivering health and their patients to work together. And you needed to have sound governance mechanisms. Who wears the pants? Where does the buck stop? And what happens with the rules and regulations, position descriptions, KPIs, incentives for the new model of care? So I've used a traffic light system there to identify what we're doing well in and where we've got some problems. And you can see there in green, I think we made huge inroads into integrated clinical models of care and really savvy, secure messaging and ability to flick information around the system. I think we've made some inroads in the way we approach change management and the way we train our teams, but I think we've really deadened the water when it comes to the appropriate governance support for the new dreams, the new ideas, the compelling service delivery models we need to deliver. So the roadmap to right care, right person, right place, right time is all about new governance models. It's all about new funding and incentive mechanisms. It's about aligning the vision for providers, the end users, and the policymakers. And it's about creating a new culture, one that's focused around one patient-focused team. So what I'd like to do now is just highlight 3 exemplars, very different from the literature, and then look at what they tell us about the future. The first one is the poster boy for international service delivery success, and that's Canterbury in New Zealand. About 15 years ago, they just felt their healthcare system was not working for their community. And so with incredible leadership from David Meats and the hospital sector, they actually spent a lot of time and interviewed thousands of patients, service providers, social providers, disadvantaged groups, ethnic groups, around what they would want to see in a system that delivered truly community-focused healthcare. And they are in red at the bottom of this chart over the last 15 years, which looks at hospital utilisation data. You can see they started very low in terms of that as they began their new health system, but they've had a flat curve in hospital utilisation growth where all the other counties in New Zealand have climbed. And what is different about their spend? As you can see there, they spend money in primary care, in home and community support, in rehabilitation, much less in in-hospital care. And looking at that graphically, you can see a much increased spend in community service provision, a decreased spend in community pathology and radiology because they're eliminating waste and duplication, an increased institutional spend in rehabilitation services, often in the community, and a massively decreased spend in in-hospital service provision. Second exemplar would be Blue Cross Blue Shield from Michigan. Again, has spent nearly a decade of statewide patient-centred medical home transformation involving nearly 5,000 primary care doctors across 1,600 practices, and that's delivered significant efficiencies across their hospital system. Now they're involving nearly 15,000 primary care physicians and specialists to participate in one of their organised systems of care. And they care for patients across all settings in an effort to streamline care, reduce duplication and waste, and make the system work much better for patients by encouraging providers to truly integrate care. And finally, because we're here in Brisbane and because I want an example of really micro-system integration, I've chosen one of our homegrown initiatives, the Brisbane South Complex Diabetes Service, which runs out of Beacon Models of Practice across Brisbane South. And that also started 10 years ago with the partnership between one of the biggest tertiary hospitals in Australia, Princess Alexandra, and our small community practice, general practice and community health service in Inala in outer urban Brisbane, one of the poorest communities in the state, very high non-English speaking and Aboriginal Torres Strait Islander population and disadvantaged groups. And we shared a common problem and a common opportunity. We had a completely unacceptable wait for outpatient assessment for patients with complex type 2 diabetes with both macro and microvascular complications. We had a lot of access difficulties for our patients for obvious reasons, but also that led to very high did not attend rates at the outpatients. And at the same time, our academic unit at University of Queensland and Queensland Health's Community Health Group had completely revolutionised the level of care and the model of care at Inala to deliver care in what we called a beacon practice manner. So our general practice continued to care for the 8,000 to 10,000 patients on our books, but we also premised our model of care on an ethos to support and extend the capacity of all primary care in our local area and better integrate service delivery locally between state-funded care, social and specialist care in areas of population need. And complex diabetes was identified as one of those areas, and we looked together for an opportunity for an outpatient substitution model within our community. And so we offered across 21 postcodes around our Inala primary care general practice, the opportunity for patients with complex diabetes and their GPs to work with us in a new model of integrated outpatient substitution. The patient was first assessed by a diabetes nurse educator and care manager, case manager, who commenced a care pathway looking at all the patient's needs and mapping those against the pathway. On clinic morning, one of 3 general practitioners with special interests would pick that up and continue that care, and then they would co-consult with an endocrinologist from the hospital, the patient themselves, and the diabetes nurse educator if needed, to plan together a goals-driven management plan where they identified what they, the patient and family, would like to do, what they would like our service of endocrinologists, gypsies and diabetes nurse educator to do, and what their general practice team and GP would be doing to support their care. And then our diabetes nurse educator worked with them around health coaching, self-management and insulin stabilisation if that was required. And these are the results, which were quite outstanding. When we looked at 12 months at comparing our geographical cohort with the cohort receiving traditional care at outpatients, you can see there that the HbA1cs in our cohort had dropped from 9 to nearly 7.5, a massively statistically significant drift. And the percentage of our cohort that had HbA1cs within target at commencement, only 14%, had risen to half of that cohort at 12 months' time, with a non-statistically significant shift at outpatient, because obviously the patients were only being seen once or twice and there was no continuity of care support. But the effect on the waiting list for Princess Alexandra outpatients surprised everyone. Because the GP with special interests, 3 of them working with the endocrinologist, was such a quick and efficient team, they were seeing 2 to 3 times the number of patients in the clinic that had traditionally been seen by that single endocrinologist. And so the clinic was able to use that capacity to establish a bone clinic, something they'd wanted to do for a very long time. And we were able to attract funding for a Centre of Research Excellence from our National Health and Medical Research Council to submit that model to a randomisation design, and were able to publish widely about the positive impacts on quadruple aim, the halving of potentially preventable hospitalisation for patients with diabetes, but also sharing what we'd learnt from that journey with others through the international literature. In addition, one of our PhD students undertook a systematic review of all the then current literature around successful models for integrated governance. Remember that red hot area that we have got to do so much more about. And she took the 10 elements that she distilled from the literature, placed them in a balanced scorecard approach, and offered those to all the primary health networks and health and hospital services in our state to assist them with their integrated governance application. So what's the secret sauce in those 3 exemplars? A shared vision centred on the patients and community need, not on their organisation. Changing the incentives, the position descriptions, the KPIs, the funding models, the rules and regulations around the way service delivery occurred. Innovative, united teams unlocking extraordinary potential because they knew their communities, they knew their patients really well. A new culture which really looked at all of us working together around that patient and their family. And all of them started by building capacity in general practice in the community sector to do much more of the heavy lifting. And time, all of those took years, building on success, learning from things that didn't go well, adjusting the model and improving. So in closing, I think it boils down to 3 things. Commitments and incentives at the macro, meso and micro level to really refocus our system around true care integration. Culture change. This will be the biggest change in health culture I've ever seen in my professional lifetime. One system, one budget, one focus, all of us working together around patient and population-centering outcomes. And finally, we heard yesterday about courage. I like the term slow burn courage that was used by our Governor-General when he was commemorating our prisoners of war in Borneo some years ago. It's the courage that keeps you going day in, day out, month after month, year after year, doing something really difficult but incredibly important. Tangible change is enormously challenging, but for ageing complex care populations, it's of paramount importance. The integration policy speak is favourable and the politics is compelling, but the necessary incentives are still largely absent and they're critical to progress change further. The heavy lifting will be by patients, families and their providers of care, and will need significant ongoing cultural change and support to be sustainable. And changing our governance levers is absolutely mission critical to achieving this. This image reminds us that the real achievements in healthcare are made by patients and their families and by the front line, the clinicians, the social care providers who work with them day in, day out to maximise their health opportunities, curing sometimes, relieving often, comforting and supporting those people and those communities always. And we have fabulous teams in health. The problem is they can only be gold medal teams when they train together, they perform together against a common metric, and they have the right coaching. Everyone in this room has the opportunity to make these sorts of differences. Please go forth and make them happen. Thank you.
Thank you, Claire. Lots and lots of food for thought in our day of looking at the hospital in that medical neighbourhood, that broader context of how do hospitals actually exist in this ecosystem of health which is changing so rapidly. Thank you for that.